Good afternoon, everyone. Thank you very much for inviting me, and also thank you all for coming, because the conference is also only a success if there is a lot of attendees, so it's already a success on that level. I would like to briefly discuss some return to sports after shoulder injury in overhead athletes. And if you look in the program, there is only one word difference between Dr. Wilk's talk and mine, because the question I want to start with is the question, if we think about return to play after shoulder injury, is there a difference between athletes coming out of surgery or athletes having recovered after conservative treatment of chronic overuse injuries? So basically, indeed, acute as well as chronic injuries may be treated with surgery or with conservative treatment. But in 3 of the 4 cases, we will have some structural damage that is documented, which means that the return to play, at least partially, is based on tissue healing. And that means that we have a time schedule in days, in weeks, in months, with increasing load on the tissue, determining when we can go to the next stage of the return to play strategy. However, if we have chronic overuse injury treated conservatively, we don't have this really clear structural damage, because very often these patients have shoulder pain based on functional deficits rather than structural damage. So it means that we have a need for a function-based return to play criteria rather than a time and a structure-based. So when we look into literature, into the so-called ideal return to play criteria, we see that the athlete should have little to no pain. He should subjectively be ready, feel ready to go back to play. He should have nearly normal range of motion and strength, and normal functional ability and sport-specific skills. However, when we look at these very general return to play criteria, we have more questions than answers. For instance, what is normal range of motion and what is normal strength? Are we happy, for instance, with the suggestion that Dr. Wilk did, that indeed they are weaker on the external rotators on their dominant side? And then also, how can we measure normal functional ability? Do we have good functional shoulder tests? So there is 4 questions I would like to consider for this talk. The first one is, which are the functional deficits that might be relevant in the fact that the athlete got injured, but also what we use as a return to play criteria? So what are the risk factors that we know that increase the risk for re-injury? Secondly, do we have reliable and valid measurement tools to measure not only the analytical range of motion and strength, but also the function? Third question will be, what are the cutoff values and what are the criteria for normal overhead function of the shoulder? And then finally, do we have any data telling me something about the return to play after conservative treatment of shoulder injury? So let's first look at the risk factors for chronic shoulder pain in overhead athletes. As you may know, research on the shoulder always is slightly behind on the research of the knee, and it's only the last 5 years that good prospective studies have been published looking at risk factors, intrinsic risk factors for shoulder pain. Now, most of these studies have been published in baseball players, but fortunately for us Europeans, there is also some studies on handball players and rugby players. And if we summarize the main risk factors that are identified in these studies, we can actually classify them into 3 categories: the range of motion, the strength, and scapular dysfunction. As mentioned before, range of motion deficits are known to be associated with shoulder pain. And as Dr. Wilk pointed out already, it's not only internal rotation and not even only total range of motion, but apparently also a lot of external rotation that increases the risk for injury. The second one is strength deficits in the rotator cuff. Within these studies, mainly the external rotators seem to be weaker in association with shoulder pain, which causes a decrease of the ratio between external and internal rotators. And then also, although there is no real 100% consensus, scapular dyskinesia has been defined as a risk factor for chronic shoulder pain, amongst others in swimmers and in rugby players. So the second question is, do we have good measurement tools for the measurement of all the facets or the variables of shoulder function? And the answer is yes, we do. We have a lot of studies that have been published looking at reliability and validity of analytical tests, but also an attempt to look for some functional testing. Now, mainly what we know is indeed that range of motion measurements can be very reliable with a standard error of measurements of only 2 degrees and a minimal detectable change of only 4 degrees, regardless of the material that you use, because we published an extensive reliability study last year using goniometers as well as inclinometers, and we also did some pilot work on the use of the smartphone with respect to the range of motion measurements. But the main thing that we have to remember is that the results that come out of your tests are not always exactly the same. It means that when you measure in the scapular plane, you might have slightly different results compared to the frontal plane. So the clinical message is then, if you want to compare your results to literature, check in the methods of the study how they really measured the range of motion, in which plane they did it. And secondly, if you want to compare your data with your own data on the long term by performing a large normative database, be consequent in your measurements and do always exactly the same. With respect to strength measurements, fortunately for the people who work in the field, handheld dynamometry has become very popular. And we know that the rotator cuff strength testing as well as the scapular strength testing is also very reliable, because we only have a standard error of measurement between 4 and 7 Newton, with a minimal detectable change between 10 and 16 Newton. However, here again, it's important to take into consideration that the result of your strength measurements is different from position to position and from procedure to procedure. For instance, the same testing performing supine or prone might have slightly different results. So again, be consequent. And fortunately, when we work together with colleagues, it's very important to do all the same procedure. With respect to the scapular dyskinesis, we know that visual observation using the yes-no method is reliable and valid compared to the 3D kinematics. It means that when the assessor, when the tester is well instructed and he knows very well how to observe scapular dyskinesis, that we are very reliable in doing so. So recently we published a paper in the Journal of Athletic Training in which we provided a new protocol for eccentric strength measurement using a handheld dynamometer. In that protocol, the patient starts with a position of 90 degrees abduction and external rotation, like it is on the slide, and then on the count of 3 seconds, we push the arm of the patient from this position to the 90 degrees of abduction without external rotation. Now, this procedure was found to be moderately reliable with ICC between 0.7 and 0.88. And the reason why the reliability is not excellent is because more than isometric testing, the reliability depends upon the strength of the tester. So you should be stronger than your patient. So it's a bit harder for female testers to perform all the testing. For the rest, most of the time, we are much more reliable, of course, than the men, but not for this time. And as you can see, minimal detectable change is between 20 and 30 Newton, which is also more than for the isometric testing. But anyway, we validated this protocol with a Biodex machine in which we did exactly the same movement from 90 to 90 at a speed of 30 degrees a second. And the correlation between both strength outputs was very good because it was 0.78. So I think that with the limitation of the tester that has to be stronger than the patient, we have an acceptable tool to use in the field to measure eccentric strength of the rotator cuff. Now, as I said before, there are some attempts to invent and to implement some functional testing. But as you can see on this slide, there is a big question mark behind the question, is it reliable, is it valid, but also is it relevant, what do we measure? Now, one of the tests that have been described in literature is what we call the seated medicine ball throw. It's a very simple test in which the patient, from a standardized position, will throw a ball as far as he can. The position, depending on the paper, sometimes is seated, sometimes is standing. Sometimes they throw with both hands, sometimes with one hand, but always very standardized. And then we just measure the distance that they can throw. This procedure has been found to have excellent reliability with a standard error of measurement of only 11 centimeter and a minimal detectable change for 30 centimeters. Now, of course, since we are interested in the value of these tests compared to some other measurements, we very recently performed a study in which we tried to correlate the distance from the seated medicine ball throw with isokinetic testing of the shoulder strength and the elbow strength. And that's a paper that is under review in the GUSPT at this moment. What we found for this test was moderate to high correlation between the isokinetic strength results and the seated medicine ball throw, which means that somehow this test gives us a little bit an impression of shoulder and elbow strength. The second test we tend to use is the Y-balance test, but then applied for the upper extremity. So in this Y-balance test, the patient is standing on one hand and then pushing away the 3 parts of the device in the 3 different directions. And this test was already found to be reliable in the study of Westrick a few years ago. And also in our study, we found excellent reliability, standard error of measurement, which is very small, 1.6 centimeter, and a minimal detectable change of 4.5 centimeter. However, when we try to correlate the results of these tests with the isokinetic strength measurements, there was no significant correlation between strength in the shoulder and the elbow and the Y-balance test results. So this means that the Y-balance test measures something else than strength. A third one, but I don't have a movie on that, is what we call the closed kinetic chain upper extremity stability test. This test has been used for a long time, amongst others by the group from George Davis in the US, and recently was also applied to some patients by a Brazilian group. And it's a test in which the patient from a specific position on the 4-point kneeling position on the knees or on the feet has to move his hand from one side to another, and they count for 15 seconds the amount of touches that have been done. Also, this test has excellent reliability with ICCs higher than 0.9, standard error of measurements of 2.3 touches, and a minimal detectable change of 3.4 touches in active subjects. So again, this test has been correlated to other tests, and in this test there is poor correlation between the closed kinetic chain upper extremity stability test and the Y-balance test. So again, it means that it measures something else. So the more difference there is between tests, the more it is my opinion that we have to use all 3 of them. Third question is, what are the cutoff values and the criteria for return to play? Now, as you may know or not, in the shoulder we don't have a generally accepted strategy for return to play, in which the best people of the world agree on their criteria. So we have to base our return to play criteria on 3 kind of papers that have been published. To start with, the risk factor studies, then, if possible, some normative databases describing the variables in a large group of athletes, and finally, some results of the variables in elite overhead athletes. So when we look at the cutoff values for prevention and return to play for the range of motion, it seems that when we look at internal rotation only, it should be less than 18 to 25 degrees of a side difference. If we consider the total range of motion, it should be less than 5 to 10 degrees, as Dr. Wilk already mentioned. Now, if you ask me as a clinician, which criteria do you use, the internal rotation or the total range of motion? I believe that in elite athletes, we should look at the total range of motion. But if you have the average patient, I mean the average patient that is active in overhead sports but not on an elite level, I believe that the internal rotation is much more important. Since we also know from a clinical perspective as a therapist that stretching into internal rotation not only increases range of motion but also decreases the symptoms. The cutoff values for the strength then, in the isokinetic testing, the ratio between external and internal rotation has to be higher than 65 to 75%. And the difference between the percentage is the result of the difference in the position in which we test. If you use the modified neutral position, then 65 is the normal ratio between external and internal rotation, but it goes up to 75 when you put the patient in the 90-90 position. But the question is, of course, what are the normative values for isometric testing? Well, as I said before, we have to rely upon normative databases that are published, and we published a paper very recently, last August, which I will discuss a little bit further into detail later. And based on that paper, when we measure isometrically, these are the ratios that we would suggest to be normal. In the 0-0 position, there should be 75% as a ratio between external and internal rotation. When we measure them in 90 degrees abduction and 0 degrees of external rotation, it should be about 90 to 100%. And when we measure them in the abducted externally rotated position, the ratio should be about 60 to 85%. So we applied this procedure on a group of elite adolescent tennis players, and this slide is to highlight the importance of normalized data, the strength data towards body weight, when you have a group of athletes who are still growing, getting stronger but also getting older. And as you can see here, we have in this column the absolute muscle strength data, and here the normalized muscle strength data. At the level of the absolute muscle strength data, you see that over the age categories between less than 40 until older than 16 years old, for the non-dominant side and the dominant sides, there are mainly everywhere significant increases in strength. But when we look at the normalized data, we see that only the internal rotation is getting stronger and not the external rotation, at least not from a statistical point of view. So if we would not have normalized that, we should never know that relatively only the prime mover, the internal rotators, are getting stronger, and the external rotators are not following. And as a result of that, the ratio between these three age categories already dropped from 74 to 66%, meaning that there is a relative decrease in strength of the external rotators. With respect to the eccentric protocol that I just presented to you, the cutoff values for prevention and return to play may be summarized as being said that the external rotation eccentric strength, when it's normalized to body weight, should be about 2 to 2.5, depending on age and sports. And as you can see here, we performed a large normative database study in which we examined isometrically and eccentrically 200 athletes, 100 females and 100 male athletes. And they were divided in 3 age categories, but also in 3 sports categories. And the reason why we went up to 50 years old in the age categories is because that is real life. We have a lot of patients in between 40 and 50 years old who come to see us, who still want to play tennis at their highest level and have shoulder pain, just like the elite athletes at their 25 have. A second important value was that the ratio between the eccentric strength of the external rotators and the isometric strength of the internal rotators should be about 1. So it means that in our protocol, there should be equal eccentric strength for the external rotators as we find internal rotator strength on an isometric way. So then for the scapular muscles in general should be stronger on the dominant side, but what is even more important is that there should be inter and intramuscular balance between the different parts of the scapular muscles. And also here, this procedure we performed on elite tennis players. We measured with a handheld dynamometer the 4 major scapular muscles, upper, middle, lower trapezius, and serratus anterior, and we normalize it towards body weight. The main thing that we found in this first study, which was published in the BGSM a few weeks ago, is that in the prime movers, meaning the serratus anterior and the upper trapezius, they were stronger on their dominant side. But we did not find that in the lower trapezius and the middle trapezius, because there we found equal strength left and right. So then the question arises, what is most important here? That we have symmetry, or that we have muscle balance within the muscles of the force couple. So we believe that in one-handed overhead sports, like tennis players, it's more important to have muscle balance within the dominant side than symmetry between both sides. So based on the results of this study, we advised the tennis players to train the middle and lower trapezius on their dominant side. We also applied this to the three age categories of the tennis players. Again, the four scapular muscles and the three age categories. And what we see here, when we look at the absolute muscle strength, and again, A and B are statistically significant, that on both sides there is an increase, especially between the second and the third age category. But when we look at the normalized data, it's again only the prime mover that is getting stronger, and all the rest is not getting strong enough. So again, we have a relative weakness when they grow older, which results in a disbalance between the muscles over age. So the last question is, what do we know about return to play after conservative treatments? Well, we don't have a lot of studies, but I will show you two studies in which they give us an idea about success rate of conservative treatment. Both studies are done on patients with SLAP lesions. The first one is from a few years ago in the AGSM. They sent out 371 questionnaires and got back 50. It was a retrospective study design on patients who had a SLAP lesion diagnosed on clinical exam as well as MRI. And they had as outcome variables some functional outcome scales. The physical therapy described in this paper consisted of stretching of the posterior capsule, scapular and core stability training, and rotator cuff training. The main result of the study showed that 50% of the patients considered the conservative treatment as a failure and they went to surgery, and 50% of them considered the conservative treatment as successful. And they had similar symptom improvement and return to sports to surgery, but only 66% went back to the previous level. In a second study, more recently, it was again a case series, but now only on professional baseball players with a type 2 SLAP lesion. There it was found that only 30% completed the non-surgical treatment with success, but the return to play was low for both treatments. 40% went back to play, but only 20% to the previous level. So these results are slightly lower, but the level of the athletes was higher. So as a take-home message, I would like to summarize that return to play in athletes with chronic shoulder pain is function-based rather than based on tissue healing. There is a need for objective criteria and cutoff values, and we have to use reliable and valid assessment tools. And I would like to end by saying that I'm very proud that next week in my hometown, Ghent, there will be the final of the Davis Cup between Belgium and Great Britain. May the best win. Thank you.